in the times of Corona. It's my great pleasure to introduce my good friend, Dr. Dileep Yavagal. So first I want to tell a few specific things about Dr. Dileep. He is from India. He had his early medical school at KM Mumbai, both his undergraduation and medicine education, MD. And then he's had his super specialty training in one of the most premier institutes in America, the Harvard Medical School, his neurology, critical care neurology from Columbia, and then went on to UCLA to have his fellowship training in interventional neurology. Currently, he is working as the professor and head of the Department of Interventional Neurology at University of Miami. What I want to say about Dr. Dileep is he's very passionate about three things. One, he's very passionate about teaching. Second, he's very passionate. Number one will be he's very passionate about India. He wants to help India to develop the thrombectomy services and stroke services in general. And he is the person behind the MT20, the Mechanical Thrombectomy 2020 initiative, which is a world global initiative to increase the number of mechanical thrombectomies, especially in developing countries. Now, he is an excellent interventionalist. He's an excellent teacher. His other research interest is in the field of intra-arterial stem cell therapy, which he believes is going to be the next game changer in acute stroke or in the treatment of acute ischemic stroke. So he is the co-founder as well as the past president of Society of Vascular and Interventional Neurology, which is the premier society of interventional neurologists in America. And we have been associating with SVIN for many activities, and he has been so supportive, and he goes out of the way to help Indians to come up in this subspecialty of interventional neurology. So with these few words, I'll come to the topic per se. With this interventional techniques coming up in the management of acute ischemic stroke, every other patient is now getting a CT angio or an MR angio done in the acute setting itself. And we come across this situation where the deficits are minimal, maybe an NIH of less than 5, but the patient has got a large vessel occlusion. So it's a good collaterals which is supporting the penumbra, but will the collaterals fail? Are we losing an opportunity to open the vessel? If the patient deteriorates or the collaterals fail, these are the doubts which we have in our mind. And this is exactly the problem which Dr. Dileep will be dealing in detail today. Over to you, Dileep Yavagal, my good friend and an excellent teacher and interventionalist. Over to you, Dileep.
Gigi, thank you so much. You're too kind, and it has really been a pleasure to interact with so many of you in India over the last so many years. It's really my privilege and honor. And today's topic is, I think, one of the main frontiers that is being addressed by the field, where we certainly come across large vessel occlusion patients with low NIHSS. And there is, as you will see, an equipoise in the field, whether to proceed with endovascular therapy or not. And I'd certainly like to address that in detail today. I'd also like to thank Gigi, Vikram, Arvind, and all of you for inviting me. I've dressed up in a suit after 3 weeks, so it's a good change in the routine in the times of Corona. So what I'd like to just address is the overall population of low NIHSS stroke. And there is large literature and growing literature in the outcomes in low NIHSS stroke. And certainly just IV thrombolysis is one major strategy that we won't go into detail today, but it's something that's being studied quite intensively. And I'm sure a number of you have seen the PRISMS trial results that have been announced. But more importantly, for today's topic, when we have a subset of these low NIHSS patients with LVO, then as interventionalists and stroke neurologists, we are really in a bind. And that's what we'll get into, both in terms of the prognosis in these patients, as well as what the outcomes are when we do EVT, endovascular therapy. And then endovascular therapy outcomes themselves, I'd like to illustrate with a number of cases that I've done and some from friends to give us a sense of where we are headed, and then talk about upcoming trials in this field. So when we look at the severity of distribution in patients who have a low NIHSS, it turns out that actually, if you look at the left-hand side of this a graph from Reeves et al. From 2013, there's actually a fair number of patients. In fact, a large majority are within about 7 or 8 NIHSS, and the low below 5, which is the definition of low NIHSS, is 5 or below, are actually a significant majority. And so that is therefore a common scenario where we get patients with low NIHSS and stroke. But the issue that is on the top of our minds when we see these patients is, will this patient, even though they are having a mild deficit, be disabled in the long term? And what should I do to prevent the disability? When you look at the data on, let's see, trying to move my slides. Okay, so when you look at this is from my close collaborator, Dr. Negar Razdagi, who is also at the University of Miami, and she put this slide together from her paper where there is a almost 36% of patients who are with low NIHSS from our Florida, Puerto Rico registry. And so this is, again, a huge number. But most importantly, in Get With the Guidelines, what was seen, if you look at this table, patients with NIHSS of 5 or less have a poor outcome. So discharged, not discharged to home is almost in the range, if you can see, of as high as 40% when somebody has a NIHSS of 5. So they may be mild now, but not disabled later, and not ambulating was also almost up to 38% in this series. So these patients are serious for the possibility of having a bad outcome. And one of the main mechanisms, and we'll talk about a couple of mechanisms here, is infarct growth. And that is where the initial data, before we did CTAs on everyone, showed that if you look at progression, that's the most common mechanism. Certainly recurrence is one other mechanism. And the most striking thing is there's about a 6% death rate in these patients due to multiple mechanisms. But we are most concerned with progression and definitely to some extent with recurrence, especially in ICAT patients. But perhaps for recurrence, one may have a little more time, but in the emergency room, on the spot, we have to make a decision whether this patient is going to progress. And we know from seeing our patients and the data that's been published that there is actually a significant number of patients who have proximal occlusion with good collaterals who end up progressing because of collateral failure. That's where the progression of infarct happens, and that's the main incentive to actually open up the proximal occlusion with endovascular therapy. The other significant mechanism is distal occlusions, such as M2s, M3s, PCAs, where the symptoms are giving an NIHSS that's low, but these are disabling symptoms such as aphasia and hemianopsia. And then recurrent stroke, which can occur a few days later, is certainly a major mechanism, especially when the underlying problem may be ICAD, intracranial atherosclerosis. So we'll talk about that also. This is an example of a patient of mine who was 70. He presented just with slight facial weakness and slurring, and he was 12 hours out. He was on double antiplatelets from the other hospital from where he was transferred, and the stroke was actually quite small on diffusion. And so here's, again, the classic example. And this patient actually was early on, so we did not have a acute vessel imaging at this point, but they were admitted to us a stroke unit without the endovascular therapist being called at that time. So this was, I believe, in 2015, very early on, where endovascular therapy was not yet become standard of care. And this patient worsened to an NIHSS of 8, and then actually got a lot worse by day 30 to an NIHSS of 11 due to infarct progression. And I bet you that this patient likely had a, as you will agree, possibly a M2 or proximal M3 occlusion that led to this worsening. So what you see with data is that early deterioration is actually most common when a large vessel occlusion is present. And also unfavorable outcome at discharge is seen when a large vessel occlusion is present. This is a great paper from Rajaji et al. Venkatesh Rajaji is originally from Chennai, and he is in Michigan now, and published this great paper when he was at UCLA, very clearly showing that LVO predicts worse early deterioration and worse outcome. And so when you look at how often LVO is present when a patient presents with low NIHSS, it's actually up to about 30%. So just because a patient is low NIHSS, their likelihood of not having an LVO is actually not a given. There is a good number of patients, almost 1/3 of patients, who likely have an LVO. So I think the policy that a number of centers in the US, and I'm sure in India, that have adopted a default CTA for all acute strokes is a good one, because you can really miss a large vessel occlusion even with low NIHSS. But the dilemma still remains is, should we go after it? You have a CTA showing a large vessel occlusion, and then the NIHSS is low. Would you harm the patient more is obviously the biggest question that an interventionalist and the stroke neurologist ends up thinking about. And here is some more food for thought from data and case examples. What you see, this is another slide that again shows that when the score is 5 or below, there is actually a decent number of patients who have an occlusion. And you can see that here is a score of just around 5, and more patients have large vessel occlusion than not. And so, but even at 0, you see large vessel occlusions, certainly way less than patients who have no large vessel occlusion, but they are still present. So again, NIHSS by itself is a poor predictor of proximal occlusion. My good friend and former fellow, Diego Hausen, published this case series from Emory that included stop stroke and Gestor cohorts, where endovascular therapy in large vessel occlusion with low NIHSS had a better outcome as compared to medical therapy. This was not a huge outcome. And this is again when you include both 0 and 1. But when you include 0, 1, and 2 outcomes, clearly the endovascular therapy patients did better. Again, this is a non-randomized trial, and something that is still needs to be tested. This is a patient that I treated with endovascular therapy. And so this is a 57-year-old lady who had migraine, hypertension, diabetes. She presented with left-sided numbness and weakness. And when she came to us, her score was only 1, and she was 8 hours from onset. And what you can see, and this is just one slice, but the right M1 is occluded. And when we looked at the imaging with a CT perfusion, that's where we saw that a large area was indeed at risk on rapid. And so this is one of the uh, way we end up triaging our low NIHSS LVOs. So it's useful to start to define this as an entity, LN LVO. And so we now have it clear that if there is an LN LVO, low NIHSS LVO, even within the early window, we will get a CT perfusion and really see how delayed this TTP or MTT is. If the delay is very large, then it possibly indicates that there is a likelihood for collateral failure. And so the patient, when by the time they arrived, were actually an NIHSS of 0 from the other hospital. And because of the perfusion deficit, we took them, we actually got an MRI to be sure that the stroke hasn't progressed. And you can see there is still a large territory that's spared. There's only a few dots of infarction. So we went ahead and treated this patient. I think I missed a slide here. And the patient did quite well. But the point that is to be noted is that these are still anecdotal case series, and a definite answer is not yet known. And so what we did is looked at what the patterns and outcomes were in Florida and Puerto Rico in our registry that was led by the Department of Neurology at University of Miami, called the Florida-Puerto Rico collaboration, and really tried to figure out what everybody is doing with these low NIHSSs. What you see is out of the 127,000 patients in this registry, we actually had about 28,000 who had low NIHSS, and out of the 28,000, 446 got EVT. So again, a small number, but this is in a state like Florida, over about 5 years, this was a significant number of patients with low NIHSS who did get EVT. And so it looks like, I'm sorry, I think this is where the slide was for that previous patient. So this was the, just to remind you, this was the MRI, and we did go ahead and found the the right M1 occluded. We did a solitaire thrombectomy with a stent retriever, and got a good reperfusion, and the patient was discharged to home on day 3. And so the outcome like this is definitely good, but I'll show you some other outcomes in a few slides down the line that make you take a pause. But as I alluded to earlier, this is actually common now to take low NIHSSs to endovascular therapy, as we see in this registry, and I'm sure you have a similar experience in your practice. What do we see from the landmark trials? And what you see is that both ESCAPE and MR Clean actually allowed some low NIHSS patients. ESCAPE cut it off at 5, but ended up including some 5s, and in the overall cohort, there was a decent number of low NIHSS patients in MR clean, again, a minority, but there were. And then Extend-I actually did not state the cutoff in its inclusion criteria. And when you look at the MR clean data, there was a range of patients that were at 3 at the lower end. So certainly in both controls and interventions, there were low NIHSS patients. That was not the case in Extend-IA, but the Hermes data set, which was the meta-analysis, showed that if you look at the cutoff at 5, there is actually a good number of patients in intervention and controls. Again, and if you look at their MRS score, there was actually a fair amount of overlap. And this is where the equipoise and the dilemma lies. As soon as you cross 5, the interventions do a lot better. So the blues are up in the top and the interventions, the reds are in the bottom. The bottom is obviously 0 to 2, better outcomes, and the controls, the blues are a lot of blue in the worse outcome. But when you look at NIHSS less than 5, there is actually not that clear a distinction. And so low NIHSS EVT remains a unclear decision from a data standpoint. Having said that, there is a clear increase in this data set, and actually I said 5 years, but this is 7 years of data from 2010, when very few patients were done in all NIHSS criteria, but as of 2017, almost 111 patients in Florida, Puerto Rico underwent thrombectomy for low NIHSS and LVO. So when we again think about these, the next thing that comes is distal occlusions. And what happens with distal occlusions and low NIHSS when you do a EVT? And so actually, I think I wanted to show one more case of progression. And this is a really good example of age and low NIHSS. So this was a patient who was actually a very accomplished theater personality from New York who was visiting Miami, and he was a extremely healthy gentleman in his 90s, but very active, still performing and such. And he came with a episode of aphasia and a mild right-sided weakness, and you can see the right M1 is cut off, and the baseline perfusion shows this deficit. Only a few areas of very delayed TTP. There is less delay. And so what do you do? And here is where I made the decision that given his age and given that his NIHSS was a 2, if I remember correctly, that we will not intervene. This was a Friday night, and we repeated an MRI when he had a slight increase or slight worsening in his symptom, and you can see that on some slices there is a larger area that's now hypoperfused. And the next morning he got a lot worse, and so this is still the initial thing. So, but he got a lot worse, and that's when we went in, and his NIHSS was, I believe, a 7 at that point. He was weak on the right side, quite aphasic. I treated the left M1 occlusion with a stent retriever, got a pretty decent reperfusion, but it took way longer. The clot was quite resistant, and that's one of the things is when you go in later, I'm sure many of you have seen that the clots may be more resistant. And unfortunately, he ended up having a pretty large stroke and did not do well. And then given his age, the care was withdrawn. So this is one of the big dilemmas where you might make a clinical decision based on age that you may not attack a M1 occlusion with low NIHSS, but really it's very hard to tell. And then when you take a wait and watch approach and decide to go in later on, you may not have the best outcome. So I'm showing you cases, as is my experience, that I've landed on both sides of the outcome line. And this was unfortunately a poor outcome where we were waiting, and just by waiting about 12 hours, we ended up not having a great outcome. So I think I'm going to finish here pretty soon, just another 10 minutes or so, if that's okay. When we look at what the distribution of occlusions is, large vessel occlusions in low NIHSS patients, clearly the ICA occlusions are lower, lot lower than in higher NIHSS patients, but distal M1s are actually not that uncommon. So ICA and proximal M1 are much less common, but distal M1s are quite common. And that's where it's very tempting to go after them. And M2s are the most common, as you would expect, and that's what gives rise to the low NIHSS. But the even more unusual for, as compared to patients with higher NIHSS, are these distal occlusions. M3, ACA with leg weakness, PCA with hemianopsia. M3s often present with aphasia. The right-sided M3s possibly are less symptomatic, but the left-sided ones, the right-sided M3s are less symptomatic, but left M3s get patients to you with aphasia, and that's where you really need to decide what to do. My sense of this entity going forward is that we will likely have different strategies for each location. Distal M1, we are very used to recanalizing with high degree of efficacy and safety, and our devices are made for them. M2s and then the distal occlusions are where I think we will really possibly end up having a different strategy. I'm just sharing my gut feeling here, nothing that's data-based yet. But this is a very important data set, again, from the Florida Puerto Rico registry that showed that the distribution is different in these cases. But when you look at recanalization rates overall from this registry, it was actually not bad. It was fairly similar. And this was, remember, from 2010. So these rates are not high like we have now, but still they are not necessarily less than the patients who have higher NIHSS. And again, the distal occlusions is where the difference is, as I was telling you, and that's where we really need to figure out if we can get devices that do well. And let's see these next couple of cases where we did them with the currently available devices, and let's see what the outcomes were. 79-year-old with hypertension AFib who presented with a NIHSS of 6. His stroke onset was at 8. He arrived at 10. He couldn't get IVTPA because of a small subdural hemorrhage he had and had to have stopped apexaban. By the time he arrived to us, his score was lower at a 5. And you can see there is a left M2 occlusion. The MTT was quite delayed, so we decided to take the patient to treatment. He was 4 hours from symptom onset. Exam had improved to 2, and that's where again this was a LN LVO, low NIHSS LVO, and we got the perfusion, took him to angio. You can see there is a big M2 missing. The superior M2, and we decided to treat. We actually identified the occluded M2 very well. We got a internal bypass with the stent retriever, but this is one of the things that's well established now, that our rates of recanalization of M2s are not as great as M3s, and we tried I believe 4 passes without success, and actually ended up having not a 2A outcome in this patient. So I think the ultimate result was a discharge to rehab, And I actually don't have a 90-day outcome on this patient. So distal occlusions end up certainly posing their own challenges that are different from proximal M1 or ICAs. And that's where the issue is whether we made the patient's outcome worse, and it's very hard to tell. This is a case that's not necessarily a low NIHSS by strict definition, but this was really illuminating to me. I shared this patient with Dr. Sacco, who was on service, and this patient had 66. He was 66. He was hypertensive and diabetic, and he had actually had a basilar stenosis that had been treated a couple of years ago. And he presented with right hemiparesis, facial weakness, and no change in level of consciousness or no eye signs. His NIHSS was 7, and you can see this is a 3D reconstruction that's not the best, but the basilar was severely re-stenosed. And you can see a hint of the right vertebral artery, the left vertebral artery, but the basilar is really poorly stenosed, but the top of the basilar was filling. And I'm sorry, I should have gotten better pictures. But the top of the basilar was filling, and that's how he was fully conscious, but he had the rest of the basilar not filling very well. And the decision was whether to go in and do a repeat angioplasty and possibly a thrombectomy, or just wait and watch. We ended up getting, this was the previous angiogram, so we didn't actually take him to angio, but just to show you that this was the previous basilar stenosis that had been angioplasty and likely had severely re-stenosed and possibly occluded. But what we did see prior to making a decision to go into angio was that the diffusion showed a established infarct that correlated with his deficits. And so based on this, our feeling was, and I have to really thank the stroke neurologist, because Dr. Sacco's feeling was that this was possibly a perforator infarct, and the large vessel occlusion was not really contributing to the deficits, because the patient was fully awake, had no eye signs. His deficits correlated with the diffusion infarct that was already set. So the only thing we possibly could do is make him worse. And so we held off on doing anything, and he did actually improve tremendously to an NIHSS of only 2 by 24 hours, and his infarct did not progress. So he was hydrated. He was on switched from Plavix to Brilinta, and he did pretty okay with conservative management. So as I was saying earlier, I'm showing you cases on both sides, because really that's where this field is, and this subset of patients, and the treatment strategy is that we really have cases on both sides of good outcomes and poor outcomes, and with both conservative management as well as EVT. And the bottom line answer is that we don't know for sure yet that what we should do for every patient. Having said that, there is definitely one issue that's very well known, is that when patients have NIHSS that are low, there is time delay that occurs, onset to arrival, because the patients don't call the ambulances soon. Door to CT is somewhat prolonged, door to needle is prolonged, and door to puncture is prolonged. And this is where we talk about a self-fulfilling prophecy. So as the case I showed you before, if you think that you want to intervene in a patient with low NIHSS and a proximal M1, there is really no reason to have any delays, because that itself may contribute to the poor outcome. So this is another important outcome we found in our registry, is that there is a delay with low NIHSS patients. When Dr. Azdagi looked at a survey, a global survey, there was actually a big variability in practice. So EVT offered immediately In the USA, it was about 34%. Canada was lower. Latin America was about 30%. And then it was very high in Europe of about 40%. So EVT offered after imaging, which advanced imaging, which basically meant either perfusion, actually mainly perfusion that was done quite commonly. So perfusion to decide was used, and then advanced imaging was requested, and then overall EVT rates, and this is because they may be delayed, were the highest in Latin America and Europe. And I think we didn't really get a lot of responses here from India or China. So that's missing. And this was mainly for M1s that EVT was offered, and less for the distal occlusion. So the need for studying this further is very high, and we actually established a registry called TRIMIS, thrombectomy in mild ischemic stroke with large vessel occlusion. And we've enrolled actually now, I believe, 12 patients, and the median age is 67. And these are fairly late patients. They come in late is what we are seeing. And we'll have hopefully data to present at the next ISC from this registry. But I think most of you know that there is two randomized trials. This was actually our idea to do TRIMIS as a trial, but this is no longer the case. We have joined ENDOLO, which is a randomized trial of LNLVO up to, I believe, 24 hours. And then in extremis is going on in France. And so I think this will really give us more data. So in summary, and I took just about over 40 minutes, thrombectomy under current guidelines does have a very low number needed to treat. And that indicates that mechanical thrombectomy is very powerful, but it also suggests that the current criteria may be too restrictive. In other words, low NIHSS, which are not in the guidelines right now, may need to be included so that we avoid patients who have poor outcomes with low NIHSS. And so low NIHSS, and then we didn't cover this, but low aspects were not included in, were mostly not included in the mechanical thrombectomy randomized controlled trials, but they represent pretty large LVO populations. So we cannot ignore these populations, and we need to resolve whether endovascular therapy should be done or not. And the initial case series and experience of mechanical thrombectomy in low NIHSS is quite favorable. Overall, I would say, but it's not established, and the equipoise continues. And RCTs for low NIHSS are, and ENDOLO hasn't started yet, but in extremis is ongoing, and hopefully will allow us to resolve this equipoise. And certainly want to put in a plug for mission thrombectomy, which is more about stroke systems of care and increasing access to thrombectomy for at least the patients who fall within guidelines. And as we know, most of them are still not being treated and not treated rapidly. So definitely appreciate all the support for Mission Thrombectomy 2020. And thank you so much for having me speak to you about this. Happy to take questions.
Thank you, Dileep. There are a couple of questions. You can see it in that question answer section.
Let's see. I may have to stop sharing my screen possibly.
Yes.
Would you mind reading them out to me while I stop?
I'll do that. Nitin Dange is asking how to explain the risk of, once again, how to explain the risk of procedure and its complication or negative results, if at all. Nitin Dange.
Yeah.
Dr. Nitin is asking.
Yeah, hi Nitin. So it's really a great question. What I say to the families and patients is that this is certainly a scenario where we don't know for sure what is the best treatment, and we do it case by case, and there is a chance that the patient could get worse. But there is also a chance with endovascular therapy, but there is also a chance that they could get worse while waiting. I find that, again, this is not a surprise. Patients who are older, above 80, families decide to wait, whereas younger patients, families want to be aggressive. So the biggest issue comes when the NIHSS is 0. And this is not uncommon, as I think some of you may have seen. I have to say that, again, it seems to me anecdotally that age ends up making the decision for families. But I tell them that we really don't know for sure.
Dr. Chandra Reddy is asking, can we thrombolize all acute ischemic stroke cases, irrespective of NIHSS, and also cases that are rapidly improving NIHSS? So rapidly improving NIHSS stroke patients as well as low NIHSS patients should be thrombolized. So that's the question. Dr. Chandra Reddy is asking.
Great. So that's a great question, and our policy is to thrombolize all low NIHSS patients. But as you know, that's not in the guidelines because the once randomized study, PRISMS, was stopped, and there was because of low enrollment, and in that population there was actually a higher rate of hemorrhage in the in the treated patients. So it's one of these tricky scenarios. One thing that helps is to do a CTA, even for thrombolysis. You could do a CTA, and if there is a vessel occlusion, especially distal vessel occlusion, you are on some stronger ground to give a thrombolysis. Now we're talking only about thrombolysis. So we get a CTA on all acute stroke patients, and especially if there is a vessel occlusion that we see, we are even more confident. But in general, we thrombolize patients with low NIHSS.
Dr. Subhash Kaul is asking, if there is equipoise, then both options, that is intervention and non-interventions, are correct, at least legally. Is that correct? That's the question. Dr. Subhash Kaul.
Yeah, that's absolutely correct. That's a great point, Dr. Kaul, and I think that's what we document in the notes also, that there is an equipoise in this situation, and in discussion with family and maybe perfusion, and the vessel was too distal, we decided not to go, or the other way around, where we say that the vessel is proximal, there is a large perfusion deficit, and the family understands the risks, and we went forward. But yeah, I think in the court of law, there is good literature to support us going either ways. I think just documenting what was the thinking in that case is good to have there.
There is another question from Dr. Subhash Kaul. What is the natural history of M1 occlusion? If we don't intervene, do they recanalize eventually?
Yeah, so we tried to look at outcomes for M1s only in our registry, and some others have looked at, and there isn't a clear statistically significant trend for worsening as compared to controls. Again, because the numbers of only M1s are low in most case series, and and they are not necessarily balanced. But on the other hand, I think out of all the location of occlusions, especially mid M1s or proximal M1s have a high chance for deterioration. As I showed you in that case of the 90-year-old who went on to getting worse. So if they have an M1 occlusion, and if they have a large perfusion deficit with a delay of 8 to 10 seconds in the mean transit time, then their chances of worsening, I think, are high.
There is a question from Ashutosh. Ashutosh, what is your approach in capsular warning syndrome with M1 stenosis? That's a very good point. What is your approach in capsular Warning syndrome with M1 stenosis?
Yeah. Yeah, that's a great question. I tend to wait and maybe do a submaximal angioplasty a few days later, maybe even 2 or 3 days. But I don't intervene acutely in these cases. There is, I think, good data to support that approach. There is a chance that if you do it very acutely, you could have a worse outcome, especially with snow plowing of the atherosclerotic plaque, and also not having enough antiplatelet activity on board. So I wait at least for 2 or 3 days before doing anything.
There is a question from Dr. Detta. What actually is meant by large vessel occlusion? Which are the vessels which are considered large? When do you clinically suspect large vessel occlusion in a resource limited setting?
Yeah, great question. So the definition of large vessel occlusion has not been set to a particular location in the vessels that we do see on CTA. In other words, any occlusion in the arterial tree from segment 1 onwards up to segment 4 in the case of MCA is considered a large vessel occlusion. And so it's a very broad definition. But you're right, in a resource limited setting or even otherwise, I think the definition probably should be stricter. But what the definition that is followed is proximal versus distal, and I think that's the point I was trying to make. That whereas at least I should talk about myself. In my practice, I'm more aggressive with proximal occlusions with low NIHSS, and much less aggressive in distal occlusions with low NIHSS. So LVOs are all vessels that we can see on CTA, and if one of the vessels is occluded, that's an LVO. But the proximal and distal classification is helpful in deciding how aggressive one wants to be. The devices for distal occlusions are still evolving, and the vessels are not as fixed. So when you try to pull the clot out of distal vessels, there is a higher chance of a complication, such as hemorrhage or subarachnoid hemorrhage. So I think proximal versus distal is what's useful. Again, in a resource limited setting, I think doing a CTA is still useful, and then you might choose not to go after distal occlusions.
Dr. Mukesh is asking, what do you do in the setting of ICAD? Placing stent in the present time is not recommended with first stroke. What is the management policy in a setting of ICAD with first stroke?
So in an acute scenario, it's tricky because a lot of times you do the thrombectomy and then you see an underlying severe stenosis due to ICAD. I used to just do an angioplasty, but a lot of these vessels reocclude because you've just opened a fresh thrombus and there is underlying ICAD that's quite severe. So even though you can open it up with angioplasty, I think the underlying vessel wall is very thrombogenic. And I'm just telling you about my practice right now, and this is not established everywhere, is to actually put a stent in such cases, unless the ICAD, the underlying ICAD is not critical. So if it's less than 70%, then I don't do that. But what I do is start tirofiban in the acute setting IV and place a stent. So over the last year or so, in fact, in severe underlying ICAD, I've been placing a stent. Now this is outside of low NIHSS, so let's make that clear. I'm just talking about any stroke with the underlying ICAD.
Dr. Sagarok is asking, do you see more hemorrhagic complications in M2 occlusion compared to M1 occlusion? That's what he meant. Dr. Sagarok.
Yeah, so the data actually does bear out that you have higher subarachnoid hemorrhages, especially because you're pulling the device around the Sylvian fissure, the curve of the Sylvian fissure, and there is increased amount of subarachnoid hemorrhage as you pull on these vessels. So overall, if you just look at all hemorrhages, they are higher in M2 occlusions. Symptomatic hemorrhages are not necessarily higher when you take all comers. I have to say, I don't remember the data with low NIHSS. I don't know if people have published low NIHSS and M2 hemorrhage outcomes. I'm not sure about that. But in general, M2s have a larger hemorrhagic complication.
Dr. Srinivasan Paramasivam is asking, do you routinely do CTP for LVO with low NHS to aid in making a decision?
Yeah. So maybe I should have really stated that explicitly, but yes, we do. And our institution, Dr. Azdagi, has been leading this charge, and it was really her data and analysis that suggested that CT perfusion to use to make a decision is quite useful, because especially with all minor stroke series, if you look at the data, if patients did not have CT perfusion deficits, then the chances of a good outcome was quite high. And so the present data indicates that CT perfusion could help you make a decision.
There is a question, what about PCA stroke with low NIHS score? Yeah. That's a common scene.
Yeah, it's very common. I can tell you from a couple of series and our own series, we are actually trying to get our series published also. The outcomes are actually fairly decent, especially with P2, P3. Safety is pretty good, and we do see that patients recover their hemianopsia. So my bias for PCAs, now that's different from ACAs, and I didn't get into each one of them because of time limitations, but this is a good point to discuss. So for PCAs, my preference is to do a thrombectomy, because hemianopsia is so disabling, and we don't talk about it enough. But hemianopsia just basically makes a person unemployed like that. You can't do your job, especially if you're using computers or driving. So PCAs, I am more aggressive. Let me just take a second to say ACAs, with leg weakness, I try to shy away. I try to not do thrombectomy, because when you pull retrievers across ACAs, the hemorrhagic complications can be higher, and a lot of times people recover leg weakness pretty well over time.
Dr. Keyur from Mumbai is asking, LNVO with significant perfusion mismatch, will you go by scan or clinical inputs?
So I do both, and a lot of family discussion, because again, as we spoke, there isn't a clear evidence that doing thrombectomy will make the patient better. I think in a younger patient, you have straighter vessels, and your chances of rapid reperfusion is high, and I tend to do that more in younger patients. Yeah, in general, I use both perfusion and clinical scenarios.
Role of EVT in TIA with LVO.
Yeah. So I think that's not an uncommon scenario. I wait in TIAs, and frankly, I think it'll be great to have some. If we have time to see what some of you think about these scenarios, but I wait for TIAs and large vessel occlusions because, again, if the patient is fully recovered, NIHSS has 0, and there is a occlusion, your chances of making them worse are on the higher side. So I typically end up waiting. What do some of you do when the NIHSS is 0 and there is a LVO?
0, no, you usually wait.
Yeah.
Unless there is a deficit, it's very, very difficult to convince the. You tell them, no, you can deteriorate. If they deteriorate, we'll take them. That's what we say usually.
Right. Vikram, do you have any thoughts about?
Yeah, I think if NIHSS is 0, I think better not to touch.
Yeah.
But we usually keep them in the ICU, tell them very clearly that there is always a chance of deterioration. And we instruct the stroke nurse very clearly that to keep checking the deficits every hourly or so. And we tell them very clearly, even if in the middle of the night, if the patient deteriorates, then we take them.
Right. Okay, Dileep, there are a lot of questions. I think we'll mail you all the questions and then we'll ask your reply. Thank you very much for making your time.